Aloha and welcome to our talk today. We are going to take a look at oxygen therapy. It's very important when we're caring for our patients that we make sure that they are maximized in terms of their ability to exchange gas, right? Gas exchange, oxygenation, so important for our bodies to be healthy and vibrant. And we kind of take breathing oxygen for granted every day, don't we? Certainly when we become ill and we have either an acute respiratory illness or a chronic respiratory illness, we really start to realize and identify how important it is and what a pleasure it is to breathe in nice, clean air, fresh air, and to get it into our lungs and just be grateful that we're alive. So, with that being said, let's get started and talk about oxygen therapy. Here we've got some images because first we always like to take a look at what things are called. And when we do oxygen therapy, usually we start out with a nasal cannula, and this little nasal cannula prongs go into the patient's nose, and that is usually connected to the oxygen flow meter, which is attached to the wall in the hospital room. Some people have portable oxygen tanks if they have chronic illnesses, and they can take their oxygen with them on the go, okay? The other thing we see here is the extension tubing that goes from the nasal cannula and connects directly into that oxygen flow meter. So, when do we need to provide oxygen to our patients? Believe it or not, oxygen is considered a drug, right? We don't just, give anybody oxygen just because. We have to be thoughtful in assessing our patients for their need for oxygen therapy. So we want to look when our patient is visibly short of breath, during an episode of chest pain, when the patient is visibly cyanotic, which means there's either a blueness around their lips or their face looks very pale, when their oxygen saturation falls below 94%, so when we check their oxygen saturation and it's below 94%, but we also use oxygen for comfort measures. So for example, we might use oxygen for end-of-life care to keep our patients comfortable. So meaning that none of these other things are happening. The SpO2 is not below 94. We're not seeing chest pain or cyanosis or visible shortness of breath, but oxygen has been ordered in this instance just to keep the patient comfortable. Other times we may need to use it is in the case of infection, right? During a common cold that might be so severe that it's impacting the patient's oxygenation status, problems with respiratory infections, lung infections, pneumonia, bronchitis, tuberculosis. We can have viral respiratory infections, bacterial respiratory infections, and even fungal respiratory infections. So these are more kind of like infectious reasons that oxygen might need to be used. We also have chronic illnesses, in which case oxygen therapy may need to be used in the case of an asthma exacerbation. So asthma is a chronic disease. We might have a patient who's acutely having an asthma attack, and we may need to use oxygen in chronic bronchitis, in emphysema, which are chronic obstructive pulmonary diseases, in acute respiratory distress syndrome, in our individual patients who may have cystic fibrosis, pulmonary fibrosis, which is scarring of our lung tissue. There are occupational lung diseases, and then there are connective tissue disorders that can also affect the lung tissue. So these are some chronic reasons for the use of oxygen therapy. And then there are some mechanical reasons why we might need to use oxygen therapy. If there is an airway obstruction, a tracheal obstruction, if there's a foreign object in the lungs, some kind of other respiratory tract obstruction, maybe in the case of pulmonary hypertension, if there's a pulmonary embolism, a collapsed lung, or a pneumothorax, which are kind of the same thing. So we want to make sure that if there is some kind of a mechanical problem with the lungs, that we are able to, of course, provide oxygen therapy. Now, here's the thing. Does the nurse need an order to put the patient on oxygen? What is the answer? Does the nurse need an order to put his or her patient on oxygen? The answer is no, you do not need an order. We never want to deprive a patient of oxygen who's needing oxygen. That is why, as nurses, we can critically think, we can assess our patients, and make a determination that the individual needs to be put on either low flow oxygen with a nasal cannula, get a call into the physician, let the physician know what's going on, have them come in and assess the patient, and then maybe order the oxygen. Okay? But we as nurses do not need an order to initiate oxygen in a patient who is short of breath. Very important for you to know that. Oxygen and medical air are not the same thing. You can see here that the oxygen is green and the medical air is yellow. You also might need to use a Christmas tree adapter to connect to the oxygen tubing. And the Christmas tree is that little green thing connected on the end of the flow meter that connects onto the O2 tubing. So if anybody ever tells you, go get a Christmas tree, which is what somebody said to me once, I had no idea what they were talking about. And I was very embarrassed because I didn't understand the lingo. But that's what it's called. I guess it kind of looks like a Christmas tree. If I took it off and unscrewed it and turned it upside down, it's green. Go figure. But that's what a Christmas tree is. If anybody tells you to go get one, it might need it emergently, so you better know how to find it and you better know what it looks like. So there you go, Christmas tree. This is what a portable oxygen tank looks like. The titration of the oxygen is a little different, right? It's not done with the flow meter. It still has a little, dial on it where we can titrate the oxygen liters, and you can see the tubing there as well. So, titration of oxygen. We've got our flow meter, and we can start our patient on 1 liter of oxygen per nasal cannula. We can then reassess the patient and see if they are stabilized on that 1 unit. By the way, 1 liter. By the way, it's really important always to maximize your patient's ability to breathe in air. So if you've got a patient that's short of breath, you've got a patient that has a low SpO2, please make sure that one of your nursing interventions is to raise up the head of the bed along with placing the nasal cannula on, putting them on 1 liter, and then reassessing. We can go up to 6 liters with the use of a nasal cannula. It's a quick, temporary way to support the client's oxygen needs. We have to make sure it's connected to the oxygen source, right? always follow your tubing. Always track your tubing. Make sure it goes from the patient to the flow meter, that the flow meter is on, and that there are no bed parts or the patient's body which is impinging on the tube, thus occluding the tube and occluding the flow of oxygen, okay? So we want to make sure that the oxygen is connected. We also want to be aware that oxygen can dry out the lips and the nares, right? The nose, the mucous membranes, and we want to be able to provide humidification of that oxygen if we need to. We also want to monitor for skin breakdown around the nose and around the ears where the tubing gets placed. So that's also important to consider. So again, we can see our patient here on nasal cannula. We can titrate from 1 to 6 liters, assessing the patient all along to see if their oxygen status has improved, right? So when we have a patient on 1 liter per minute, okay, we are supplementing them with 24% oxygen. When we bump it up to 2 liters, we're bumping it up to 28%, 32%, 4 liters, 36, and so on. You can see how as we increase the liters per minute, we're increasing the percent of oxygen, okay, that the patient is getting. Now, this is called FiO2. If you hear anybody talk about fraction of inspired oxygen, or FiO2, that is what they're referring to when they are saying the patient is on 4 liters, 36%, right? So, I'm going to ask you a question. What is the fraction of inspired oxygen in the air we breathe? What is the fraction of inspired oxygen in the air we breathe? How about 21%, right? 21%. Each additional liter of oxygen adds about 0.3 to 0.4 to the percentage of inspired air, okay? So if there's 21% oxygen in the air and I add 1 liter of air onto my patient with their nasal cannula, right? Then what I've got is an FiO2 of about 0.25 or 25%, okay? So an FiO2 of 21, room air, right? If I add 4 liters of oxygen, I'm adding about 16%, right? And I'm going to end up with an FiO2 of 36%. So as we increase the liters per minute, we're increasing the fraction of inspired air, all right? So let's look at that again. So FiO2 at 1 liter is 24, at 2 liters is 28, at 3 liters is 32, etc., etc. Okay? So now you understand, hopefully a little better, what people mean by FiO2. So remember, the fraction of inspired oxygen sitting here right now as I speak to you, my fraction is 21%, all right? Okay, so what if the patient's nose and lips are moderately dry from being on 4 liters of O2 per nasal cannula for a couple days? We want to add humidification. And we can do this for up to 6 liters on the nasal cannula. And it's going to help the patient be more comfortable. And we do this by connecting it to our wall, right? Our wall apparatus. We connect the humidification bottle, and then we connect our tubing to the humidification bottle, and then we connect that tubing to the patient so that as the oxygen is coming through the tubing, it is getting humidified. Okay? If the individual requires a higher concentration of oxygen, right? So let's go back. We've basically said that on 6 liters per nasal cannula, they're maxed out at 44% FiO2. If they need more than 44%, we have to move to a different type of mask. This is called a simple mask, and it usually helps provide adequate humidification of inspired air, right? But you can switch it out for the nasal cannula while they're eating, all right? And so the simple mask really kind of starts at that 6 liter point to 7 liters, 8 liters, 9 liters, and up to 10 liters, right? So the simple mask is going to help have a natural humidification because they're going to be breathing inside the mask. And this is a way to increase their, also if somebody for whatever reason just isn't tolerating a nasal cannula, or you decide that a simple mask is necessary because of higher oxygen needs, right? There is a partial non-rebreather where the O2 flows into the mask and the reservoir bag during inhalation, all right, providing higher concentrations of O2. If one of the tabs is closed and one of the vents are open, right, a partial non-rebreather has an FiO2 of around 70 to 80 because the room air is mixing with the source of pure oxygen, okay? So here we can see a partial non-rebreather to work. The flow rate must be set to a level that allows the bag to go up and down as the patient is breathing, right? So that's what we want to look for when we are titrating this oxygen. The bag should not deflate completely with inhalation. If it does, the flow rate may need to be increased, okay? A non-rebreather, the vents are closed, all right? So if the vents are closed, we've got an FiO2 of 90 to 100%. The most oxygen that can be delivered via a mask. We want the client to rebreathe some of their CO2 in this case to increase their respiratory drive, right? If this is inadequate, depending on the situation, the next step would be to intubate the patient. Okay, that would be the next step here is intubation. And so the vents are closed. We said the FiO2 is about 100%, and if this isn't working out, we got to go to intubation, right? We talked about that before. When we intubate, we put in an endotracheal tube or an ET tube. A laryngoscope is used in order to prepare the airway for the ET tube to be put in. Once that happens, the patient can then be put on a mechanical ventilator and in the intensive care unit or another type of higher level nursing care unit. I'm not going to go into a lot of detail about this. You can learn more about this if you would like, but here you see a patient in the ICU on a mechanical ventilator. Kind of is a basic understanding of how the machine is working to oxygenate the patient. There is also another type of FiO2 specific mask that can be used. It's called a Venti mask or a Venturi mask. And this is really designed according to the Venturi principle, which allows for more precise specific amounts of oxygen. So this isn't really titrated by the wall or by the tank. It's actually titrated by this Venti adapter. So here you can see the different colors of adapters coincide with the different percentages of oxygen from 24 all the way up to 50%. And so let's take a look at what a Venturi mask looks like. This is a mask that has an adapter that is adjustable. So you can adjust the concentration of oxygen on this apparatus. And if we take a closer look at it, we can see here that there are, there's a strap in place, there's exhalation ports, there is where the removable adapter goes and then connects to the oxygen tubing and connects to the wall. Okay, so the same FiO2 is delivered in every inspiratory breath. So this may be used in the case of a CO2 retainer or for a pulmonary embolus. So what do I mean by a CO2 retainer? What does that even mean? So I have a question for you. What stimulates us to breathe? What stimulates us to breathe? Do we decide to breathe? Do I say to myself, Mary, you should breathe right now? No, I don't control it, right? It's an automatic function in my body, right? It's automatic. But how does our body know when to take a breath, right? Well, if you answered that CO2 accumulation is our major stimulator for breathing, you would be correct, okay? But some patients that have chronic obstructive pulmonary disease, chronic bronchitis, emphysema, they build up a tolerance to CO2, meaning that their respiratory drive is not really triggered by a buildup of carbon dioxide like ours would be, okay? So what a CO2 retainer is when a COPD patient can develop a tolerance for high CO2 levels, and that in theory that drive to breathe, right, would be hypoxemia, right? But what would happen here is administering high doses of O2 might actually decrease their respiratory drive, thus causing a carbon dioxide-induced narcosis, okay? And this is when you find a patient who is a CO2 retainer, somehow was put on a high level of oxygen therapy, and they kind of went a little in a daze. They're a little unconscious, they're a little hard to arouse and wake up, and it's because they have these high CO2 levels, and now we're giving them too much oxygen, and it's actually decreasing their respiratory drive, thus causing this narcosis, right? And so what we want to do with these particular patients is that we always want to start them at a lower flow rate. We want to try to keep them on the lowest amount of oxygen that keeps them comfortable, all right? And the physician might write an order to titrate their O2 to maintain their O2 saturation at around 92%. Well, earlier I said that you as a nurse might make the decision to put your patient on oxygen if their SpO2 fell below 94%. That is in a person that does not have a chronic respiratory disease. Some patients with chronic respiratory diseases live at 92%. Their SpO2 doesn't go above 92%. Some of them even live at a lower SpO2 than that, okay? They adjust to it, their body adjusts to it, but you will always find that patients with chronic respiratory diseases always want you to increase their oxygen, because I don't know if you know what it feels like, but being air hungry is a very uncomfortable feeling. It makes people anxious. So as nurses, we have to be aware that these folks want oxygen. They feel uncomfortable. However, people have this concern about giving them too much oxygen, thus causing this narcosis, right? So it's really important to work with the physician and work with the patient and try to titrate their oxygen status to something that is safe, all right? We don't ever want to deny oxygen to our patients. The only example that I can give to you is that I've scuba dove before, and there were times where we were diving, maybe we were diving off of a boat or in a situation where I was expending a lot of energy before I hit the water. And then when I got in the water and I put on my regulator and I started to descend, I started feeling really air hungry. And so I was taking big, deep breaths through my regulator, right? And I'm telling you, if you've never experienced it before, it is not a pleasant experience. So please, nurses, let's be gentle with our CO2 retainers. Let's understand that they want oxygen and that we need to safely titrate their oxygen so that they can be comfortable. All right? This always requires careful baseline assessment and ongoing assessment of what? Their mental status and their vital signs, right? I mean, you know, you're going to give them a little bit more oxygen, monitor them, okay? Monitor your patient, watch your patient, okay? So in this image, we can see a comparison of some of the different types of masks that we've talked about during this lecture. And again, there is such a wide range of information regarding all these things. My goal in this talk was hope to just give you a little bit of an introduction to oxygen therapy. I hoped you learned something. If there are things you want to go and look up and learn more about, I encourage you to do that on your own. And until next time, aloha.